Dr. Reem gonna talk about ultrasound in obstetrics, advances and future directions. Thank you very much.
Thank you very much. It's a huge honor for me to be here today, back in my hometown. Amidst many dear colleagues and friends. And to speak after such distinguished physicians that came from Tripoli. I thank the Order of Physicians, my dear colleagues, Dr. Ali, for giving me the opportunity to be amongst you today. And now I'm going to talk about ultrasound in obstetrics, advances and future directions. We heard beautifully about global health and the huge need that we have for women's reproductive health and neonates as well around the globe. And ultrasound ties into all of this because by early detection, we can direct, we can get women to the places where they give them the optimal care, and with proper prenatal diagnosis, we can get these neonates to deliver at centers that can handle them, and with all the advances that we have today, even offer in utero therapy. So I'm going to focus on imaging, and I am going to start a little bit like Dr. Ahmadi started, historically about where we came from. And imaging in obstetrics really dates back to Da Vinci, and they used to do schematic drawings of the fetus from cadavers of pregnant women. And it was in the 1700s that the capabilities of bats for echolocation were discovered, and this was first used in submarines. It wasn't until the 1940s that we translated this to medicine, and the first tumors were diagnosed in 1942 using ultrasound. The first images that were described in medicine in general and that led to the foundation of the American Institute of Ultrasound in Medicine was in 1952. Now, it was Ian Donald and Stuart Campbell who first used ultrasound in obstetrics. This was in the 1960s, and it was in the 1970s when we have the first reports from detection of anomalies in the fetus and the first reports of spina bifida and anencephaly. 3D ultrasound we've had since the 1980s, and it's 1991 that ISWOG was first founded. We are celebrating our 35th anniversary starting in the coming year, and so much has happened since then. We started with machines that filled an entire room. Then they got more and more sophisticated and smaller to the point of portability. And today there's no limit. And the latest that we have available is actually a patient-operated ultrasound, where you can see here the probe serves as a cradle where the patient's smartphone sits on it. And then using telemedicine, the provider can adjust the image, can guide the patient, and can get key information in times of in-access, for instance, times of COVID, times of wars, and times of natural disasters, among others. Now, there have been tremendous advances in the quality of the image, and it's really amazing for those of us who have been practicing the past decade or so. And I will give you an example on a grayscale image. You can see the first trimester fetus on the left, and this is the newest radiant grayscale. I call it like Michelangelo of imaging, because it is so fine. You can see every single line, and really the details are unbelievable. You can see the muscles of the abdomen, of the chest, and we have to relearn really how we look at things. Look at the fetal heart 10 years ago. This was an image we would be very proud of, and look at today. Look at the resolution, look at the detail, look at the clarity. It is really unbelievable. Now, color Doppler is one of the techniques that we cannot use, we cannot function without. It's so critical, and we've really had tremendous advances as well. We start with the regular color that we had going back 10 years or so. In the past 5 years, we have the radiant color, which kind of adds a 3D effect to the image. And then we had the slow flow as well, which is very sensitive to tiny structures. This is a first trimester heart that looks almost like a second trimester heart. And just in the past year, we now have the most amazing graphic flow that shows you the red blood cells as they are swirling within the chambers of the heart. You can add arrows to it, and it will tell you what the direction of flow is, especially in certain anomalies. And you can freeze it frame by frame, where you can see the vortices of blood, how they are swirling in different areas. So we really have so much learning now to catch up with what this technology allows us to see. How do we interpret it clinically, and how do we use it to improve where we are today? Now, many of you know me from my days here in Tripoli. My area of expertise and my passion is the first trimester fetus, because we can reassure mothers, a very powerful tool early on as to the well-being of their fetus. We can also detect early and send them to where they need to go, whether it's going to be in utero intervention or delivering at a center of excellence. We can do a lot with location. We have so many of our excellent reproductive endocrinologists here, and we know that we're seeing so many more cesarean scar pregnancies, heterotopics. So with the equipment we have, the first image that I show is a heterotopic pregnancy, where you see the gestational sac properly positioned, but look at where the cesarean scar was. This was a heterotopic with a pregnancy in the scar. Here's another. We're using 3D ultrasound. Yes, you don't need 3D to make this diagnosis, but you see the ectopic in the cervical canal. You see the fetus. It did have cardiac activity, the yolk sac, all in the cervix. Again, we know ectopic pregnancy is one of the biggest killers and the biggest causes for maternal morbidity and mortality. And this is a more recent, very challenging case who presented with very high beta HCG. Again, you see the healthy intrauterine pregnancy with the fetal pole and the yolk sac, but she had also a heterotopic. It was an intramural heterotopic, a very, very rare occurrence within the myometrium itself. Now, multiple gestations, of course, there's so much risk with multiple gestations, but just trying to determine, is it a monochorionic, is it a dichorionic, is it a monochorionic in case of entangled cords, as you see in this case, and so ultrasound plays the critical role. The earlier you look, the more accurate you are in determining chorionicity. Now, what has really pushed us is the availability of guidelines. And during my presentation today, I'm going to just highlight the first trimester and the fetal heart guidelines. And with the first trimester, I alert you to the ISWA guideline that was just revised and released. That has critical components of what we should minimally look at. This is the basic, when we look at the fetus between 12 and 14 weeks, and the advanced based on the equipment you have, the expertise, and the ability. And of course, as you gain expertise, you add on to what you can offer your patient. And I will show you just some examples about the first trimester. The first trimester guideline has a component, several components, where as you scan the fetus in the second trimester, you're going to use your sagittal, your axial, and your coronal planes. And you are going to look at biometry exactly as you do in the second trimester. You look at the placenta and cord insertion. You look at the fetal head, brain, and the face. You look at the heart and the vascularity. You look at the abdomen and pelvis, and you look at the extremities. And I will show you just a few examples from what I call the most important plane or sweep to get of the fetus, and that is the mid-sagittal sweep. All of you are familiar with measuring the nuchal translucency, or what we used to say here, samek al-ra'bi. This was introduced way back in the early 90s as a very potent modality to screen for aneuploidy and cardiac abnormalities. Dr. Fatten and others have now taken us in the biochemical world and in what we can do with genetics to not using the nuchal as a screen, because we have the non-invasive prenatal screening that is so much superior for the detection of aneuploidy. But what we still are left with now is the ability to do a full anatomic assessment of the fetus at this point in gestation. And this plane is critical. I show the image on the left because those of you who are still getting the nuchal, this is not the correct plane. You see the connection between the maxilla and the nasal bone. This is the frontal process of the maxilla. You're not truly mid-sagittal. But this mid-sagittal plane has so many critical markers within it. It has the nasal bone that helps us rule out aneuploidy, a nice continuous maxilla to rule out facial clefts. We can see the mandible, that we don't have any micro or retrognathia. We see the thalamus, the midbrain, sphenoid bone, brainstem, medulla oblongata, future fourth ventricle with its choroid plexus, cisterna magna, and occipital bone. And of course, we measure our nuchal. And each one of these structures can point us to an anomaly from just one single image. And as you sweep and you're trying just to date your patient to measure the CRL, sweep parasagittally, don't stop, because I will show you on the left-hand side, you can measure the CRL, make sure you don't have anencephaly. You can see that the stomach is there and you rule out congenital diaphragmatic hernia. You can see cord insertion and rule out a large abdominal wall defect, and you can see the bladder to rule out renal agenesis as well. And with the sagittal sweep, you can detect many anomalies. I don't have the time to go through all of them with respect to the brain, the face, the heart, the abdomen, and the skeletal system. And just a few examples to show you. Just trying to sweep through this fetus, I hope your eyes are directed towards the head, where you see this very large, well-circumscribed cystic structure. This was a very large arachnoid cyst. This was detected in the first trimester. And here, I hope you can see from this profile that the proximal third of this maxilla is missing. This was a baby with a large facial cleft. And this is another case where, as you're sweeping parasagittally, you can see that you have a very large abdominal wall defect. You can see the liver is herniated, so is the stomach. But if you really look closer, you're going to see that the tip of the heart is also outside the cavity. And you can see it with color Doppler as well. And these are all constituents of pentalogy of Cantrell. And here's another case where we all know that there are physiologic limitations as the fetus develops, because usually we have natural exomphalus. The abdominal contents are outside, and it's not till about week 11 that the abdomen closes and the contents are internalized. But this definitely is not normal. You see this cauliflower appearance in front of the abdominal wall. You see that the cord inserts to the side, and using 3D, you can see gastroschisis. And here is a fetus, again, at around 12 weeks, where you can clearly see that there is an extra digit. Of course, this is very minor, but you can detect polydactyly. In addition to talipes, sweeping through again, you can clearly see the lower extremities and the talipes. And I will end with this case, because even if you scan and you find no cardiac activity, as was with this fetus, we owe the patients an answer. We owe them counseling to prepare them for the future. So look further and try to decide, am I able to give her any additional information? And with this case, she came in with a fetal demise with a very large abdominal wall defect. And initially, that was the diagnosis. But looking carefully, you can clearly see, with adjusting the gain, that you have something that is connected from the membranes towards the fetal abdomen. And this was a case of an amniotic band sequence. It completely changes your counseling and your management for future pregnancies. And I will show this clip for you all in the audience, the obstetricians, of course, but others can try as well. This is a 12-week fetus. Look at this fetus and see, is there anything from the prior clips that I showed you that captures your attention? And I hope you can see that there is holoprosencephaly. There's a proboscis. There's something protruding in front of the face. The lips are irregular. There's a break in the maxilla. there is polydactyly, and there is an omphalocele, and there was talipes as well. Now I'm going to move to advances in the heart. We have a workshop tomorrow dedicated to the heart, so I hope the obstetricians will be able to join us. But again, I point you to guidelines. We have guidelines from the American Institute of Ultrasound in Medicine, at the core of which is the 4-chamber view, a very critical view, and of course, ISWOG's guidelines again to screening the fetal heart. And in the first trimester, we use the same approach. You always want to establish situs, but the keys are your 4-chamber view without color, your 4-chamber view with color, and determining your cardiac axis, and your 3-vessel trachea view. And I hope that by utilizing a very simple approach, whether it's your first or second trimester, we can easily start to pick up the abnormal, not necessarily make the final diagnosis, but recognize when something is not right. Now, this is the newest technology that, for me, I look at it and it's mind-boggling, really, but this is the 4-chamber view and the 3-vessel trachea view, where you freeze the frame at any point in the cardiac cycle. And remember, the heart is the only organ that changes shape in systole and diastole. So if you're going to interpret anything, you have to be very mindful as to where you are in the cardiac cycle. But through these planes, you can technically detect over 90% of congenital heart defects. And we recently wrote a commentary on the sweep that should go up not through only the 3-vessel trachea view, but to the upper mediastinum, where you can see the brachiocephalic vein. And I will not read, well, it played good. So this is your 4-chamber view, your crossover, 3-vessel trachea, and finally your brachiocephalic, where you see the thymus in front of it. Why the 4-chamber view? I am not going to read through all of this. Tomorrow we will cover this in detail, but it is a critical view to obtain. It allows you to rule out nearly 2/3 of congenital heart defects. And combining it with the 3-vessel trachea view, as I mentioned earlier, we can pick up more than 90% of congenital heart defects, the most common anomaly to affect children. 1/3 of these children will have other abnormalities, and it is the #1 cause of infant mortality is congenital heart disease. We can do this across gestation with the technology we have today, so you can see 10 weeks, 12 weeks, 20 weeks, and 39 weeks. Same for the 3-vessel trachea view, whether you're at 13 weeks or 23 weeks, the equipment today allows us to get these images. Here's an example of a tetralogy of Fallot, where you can see how this technology helps as well. Yes, we're able to make this diagnosis even in grayscale, but with adding the arrows, you can see your membranous VSD, you can see the aortic override. It shows you that the blood is coming with the arrows from both ventricles. And here's a minor anomaly. This is an apical VSD, where again with the arrows you can see that there is bidirectional flow. This is because the pressure in the ventricles is equal at this point in time. Now, I'm not going to talk about critical congenital heart defects. Those are the defects that need immediate attention at birth, but I've listed them here on the left, and I've highlighted whether a 4-chamber view or a 3-vessel trachea view can pick them up, and you can see that if you just look at these 2 views, you will pick up all critical congenital heart defects. Anomaly detection, I will just show some examples: a hypoplastic left and a right heart. These are all first trimester cases. A coarctation detected by an abnormal cardiac axis. Tetralogy of Fallot, also from a simple cardiac axis. Epstein's anomaly with a very large right side of the heart. A single ventricle where this heart has only one chamber, double outlet right ventricle, double vessel sign in a case of heterotaxy, common arterial trunk, tetralogy of Fallot, among others. Now I'm going to move to AI, and we heard beautifully through the afternoon today about what the capabilities of AI are. Are we threatened? Yes, we are, but we have to outsmart it. We have to know how to use it. As we've heard, we have to use it ethically. We have to make sure it's equitable. AI will do tremendous improvements for healthcare globally, but we have to make sure it's not the rich nations that are the ones that can use it. As we heard from our experts earlier, it is so critical that we regulate this, this treasure that we have today. So with AI in ultrasound, it really enhances efficiency, and I will show you examples of how. It improves the quality. It can act as a quality control. It helps tremendously with education, and of course, those of us who scan and who have suffered enough injuries with ergonomics, because if it makes us more efficient, shorter scanning times, it safeguards our aging joints. Our ultimate goal is to improve detection, but again, equitably, I would like to reiterate that. And there have been many publications. Those of you who are interested, I will just point you to a publication from Drucker. This was one of the first in 2020, highlighting the use of AI in OBGYN and in obstetrics per se, primarily for probe guidance. For biometry, we think biometry is easy. It's not. You'd be surprised at how much we over and underestimate fetal weights even today. For completing anatomy scans and highlighting anomalies. And for structure generation and measurement, there is available today AI on certain machines where you get a volume of the fetal head, and just by the press of a button, it will automatically pull out from that volume the 3 key planes, and by another press of a button, it will place the calipers for you. Pregnancy dating is very challenging, especially in underserved areas of the world. University of Oxford has been pioneering this with something called Tracer. It is a handheld, portable, small device that can detect the cerebellum and can date the pregnancy based on the transcerebellar measurement. And so this is to make it easy for a layperson who doesn't have the technical skill to use a simple device that's AI-empowered to do that. And we've been training machines. Deep learning algorithms are when you feed normals into an AI system, so they learn what normal looks like, and then they can recognize the abnormal. Much work has been done in the 2 most challenging areas that I would like to highlight: the brain and the fetal heart. And today, there are numerous companies and startups working towards that end. This is a very recent scoping review of AI in our specialty, and I will not read, but there are many areas that this is being used in. And at the SMFM, just a couple of months ago, Society of Maternal Fetal Medicine, a study was presented where using an iPad that you connect to any ultrasound machine, it can pick up congenital heart defects. So we are moving in the right direction, slowly but surely. Simulation, this is from one of my trainees at the University of Florida. This is an iPad-based simulator where you use your phone as the probe. And look at how incredible it is that it color codes every single structure to teach the trainee what they are looking at. Not only moving the probe to obtain the image, but structure recognition as well. The future is very exciting, but very scary as well. Regulation and really having a multidisciplinary approach, as was highlighted throughout the day, is the key. We need the global organizations to talk together. We need this cross-fertilization, if I may, so that we can all come together, lay the groundwork to benefit humanity and move us into the future. I will show you what there is today. This is on the latest equipment that I am privileged to have at my unit. But now I have equipment, and all I'm doing now is I'm sweeping over the baby. You will see how AI in this equipment will stop, recognize the plane. You can see the list on the left-hand side of the key structures that we have programmed it that we want to check. The equipment, is, you will read here, transventricular. The color will change when it's of good quality. It will capture it and measure it on its own. So watch. All I'm doing is sweeping. That's all I do. And slowly, you can see that it is trying to recognize. It doesn't like the quality. Yellow is acceptable, green is best. And we've programmed it that it can capture the yellow. And when it captures it, you can see that it put a purple dot there. This plane has already been acquired. And so this is for efficiency and throughput, that instead of me having my mental checklist, I sweep through the baby, and the equipment will recognize, will capture and save, and now it's trying to get the spine. And I'll move to another clip. This is at the AC, and you can see it captured it. It put the check mark. This is going to be available on many machines going forward. So to conclude, I hope I've been able to show you what exciting times we're living through. There are tremendous technological advances, and it's very hard to stay up to date with all of them. We have to utilize our guidelines. This is the key to standardize our approach. And we have to recognize what the value of AI is, though know how to introduce it. This will translate into enhanced throughput, provider empowerment, because it gives us confidence, it helps us improve detection rates, and of course, ultimately, better patient outcomes. I thank my group of sonographers at the University of Florida. None of my work is possible without them, and I thank you for your attention.